Hello, this is Dr. Paya, who is currently working as Deputy Chief of 44 ASON project, one of the USAID projects focusing on initiative on hygiene, sanitation, and nutrition in Afghanistan. And the former Health Program Director of Future Generations in 2005, 6, and early 2007. I'm going to discuss and talk about a project which was, the focus was on women empowerment in Afghanistan. It started in June 2005 and ended March 2006. And it was a one-year trial of the Future Generations model for training of CHWs. The Future Generations methodology focus was on three main elements: the ownership, value, and the how to facilitate the work. First of all, the community, the focus was that to be given the full ownership, and this was helping the project and also in general, the work to be more sustainable. And second, the community were supposed to be assisted with the understanding of the values of the work. And the focus of this part was to have their active and full participation, and then mobilize the communities to understand better the values. Also, positive changes, we were thinking, must be facilitated, not just to be imposed, because of the sustainability to be ensured, and also to have full empowerment of the communities. The central theme of the project was the operational research project demonstrated a successful model of community-based and participation. The changes in health practices showed almost complete coverage of the communities. More important, the changes in behavior and social norms, that was one of the main elements. The change process shows also that it was not about only what's going to be done, but more importantly, on how the changes have happened in those communities. The Women Village volunteers, actually the analysis of those potential capacities of the village women volunteers defined three main groups who could ensure the sustainability and contribute to the community-based healthcare within those communities. The first one was the CHWs, and this part, mainly the communities came up with a selection of the mature and respected women within their communities, and specifically they were mother-in-laws, and in Afghanistan culture, within those communities, the mother-in-laws, they have power, respect, and this was one of the main areas. And the women action groups was the second group, and they were mainly, the focus was to have more young women with children, and more active, and also interested to take part and be engaged in the project and work with the women, with other community members to improve their health status. And the last one was the community statisticians. And they were very young, with some literacy and numeracy skills, and they were interested to work with the community, again, with all these groups to improve the health situation in their communities. There were 5 interventions within the project, and the first intervention was about the women-only workshops. We had five days of workshops, and it was like in general, in total, 25 days. A little bit different from the government manuals and also methodologies, because in which they had continuous days, not just 5 days. And within these 5 days workshop, the around 20 or 20 plus community health workers who are already selected, they were attending these workshops. They were meeting in the village, and the house, one of the houses which was selected by the community and also the community elders, involvement or and also active engagement of the community religious leaders. In one part of the village, which was somehow isolated but is still part of that village, they were sitting meeting there, and the focus of the topics on acute care, child diarrhea, pneumonia, malnutrition, sepsis, and other infections, plus first aid. These were the areas in general. And prevention, on the prevention side, just the routine vaccination available, which were available within the health facility and also in the country. That was the focus. And learning to communicate with the neighbors, changed to how to change the beliefs, practices, women's and women empowerment, because in it was innate practices and social beliefs that they were sharing with each other. Second intervention was the pregnancy histories, and more coming to the during the first workshop, in first 4 days, at least one woman, but most probably it was like 5 women, they were sharing in the morning their pregnancy stories, and also with others. Specifically, focus was that finding those elements that they could work on that and they could prevent or avoid. And this was the sharing of life examples. And the role of facilitator here was just to ensure everybody is listening to the entire story, and also see then later on how to link this with the practical sessions on the relevant topic to come up with the local solution for that, and also inject some sort of additional information and knowledge for the future for better learning. They were attached or bonding as they were sharing the pregnancy stories, and also jointly realizing their successes and raising their families. The learning schedule was based on their own experiences, priorities, community practices, and culture. And it was not the directed by the facilitators, specifically with a specific out of context or culture information. Intensive for continuing discussion, that was also another element, which was more according to the season and real life experiences. And the picture, it shows how they learn what to do, but more important, it was also important for them how to convince their male members, assisting them with these in different health aspects within the family, and also with the challenges. Each, there were, the third intervention was about the women action groups. Each CHW was responsible to organize up to 10 neighborhood leaders, among which are the cohort of women with young children, because the main focus was to engage those children, those women which who had children, at least one or two under 5 children, and were able to also work on this in these groups, and with additional with the family members within their communities. The total village coverage, as each CHW was around responsible, was for 50 plus families. And the cascade learning process, first of all, it was the facilitation role of the person who was leading or assisting them within these the workshops. That was the main role of the facilitator, to inject the relevant knowledge, and then from CHWs, these selected CHWs then to women action groups. This was also ensured. And they had also monthly meetings. And the main topics for these monthly meetings was based on the season, and also those relevant to those stories, and also relevant to their the current challenges they had within their communities. And they were meeting in a comfortable place in one of the houses. However, it was they had a selected place, but sometimes due to better engagement and also better improving the internal communication among themselves, they were changing those selected houses and shifting from one part of the village to other part of the village, to also to ensure the better inclusion and also the participation and empowerment of entire village. The fourth intervention was the community statistician. As they were young or third age cohort involved in the process, they had some literacy and numeracy skills, and they were able just to record some of the, based on the knowledge, and also based on some short trainings they have received, to assist the community health workers and also women action groups with those recording of the information and also data available with the specific topics. Their primary function was to ensure community ownership of the village, their own statistics for the annual work plan, and also the quality and completeness of data, because some of the CHWs, they were not, most of them, they were not, they were illiterate. And these community statisticians, they were assisting those CHWs. Selective channeling of data to this data they were collecting, it was linked with the HMIs of the health facility, and also they were working closely with the health system and linked to the health facility by the community health supervisors. And the potential for vital statistics for reporting of surveillance for selected illnesses as per the need of those villages, and also based on the topics they were receiving the training through the 5 days of workshops. And we can see the community statisticians recording the stories and also data from the illiterate women who are not able to do that task. The fifth intervention for the project was scaling up and using the learning centers. And the regional and national cluster of best performing villages to be linked with the BPHS, Basic Package of Health Services, the system, and also through the also engagement of the Shura, and somehow it was through their control from because each health facility, they had a health Shura, and also from different villages, they had representation there, and somehow this was under their control. Transformation of the cluster of villages into regional learning centers, and action learning local CHW trainers, facilitating the learning process with educational and cultural credibility, since they were still working and were responsible for the health for their communities. And the experimentation, local experts trained to adapt local culture and needs for improved local solutions with guidance from formal health system. The entire one of the, I would say that the main focus of the project was within local solutions to come up and to adapt the available system, and also the knowledge how to be used locally and also to be managed by them. Then midwives and village volunteers in the reproductive health centers. Mostly in each health center, there were, as per the health system basic package of health service, there is one midwife, and these midwives were responsible to support the community health workers, these female community health workers, to the female community health supervisors available. As the community health supervisors were the link between the health facilities and also the community with the community health workers. Every village has the community statistician also, that was another link, working closely with the community health supervisors, and also the on the other hand with the health facilities to transfer the available and recorded data and information received from the community health workers and also family health action groups. The community statistician were the active, I would say, part of this project, because the intention was to have the data and also empower the communities and villages to control their own data, and also have the full potential to share proper information and on timely basis just with the health facilities. And also for sure that is the trust element was also there, because once the potential was there, they had the ownership of their own data, and also and everything was understood by the community statistician, discussed with the women action groups, discussed with the community health workers, and also then shared with the health facility, receiving the feedback and also the necessary responses, even sometimes based on this information shared by the community statistician with the health facilities. There were additional sessions by the community, by this community health supervisor, and also midwives attending some of these sessions of women action groups and assisting the women action groups and also CHWs on specific topics, and also sharing and supporting them with the needed information and knowledge. Some of the pictures, the education materials, and also we can see the young but still the grandmothers in the process, engaged in the process. And the methodology was totally a total of 60 CHWs trained, 20 in each site, and it was as we had the process in 20 in two provinces, in Ghazni province, Jaghuri district, and also Bamiyan province, Yakaholang districts, two provinces of Afghanistan. 20 of these CHWs were in Jaghuri district of Ghazni province, and also the remaining 40 in Yakaholang. And where one or two CHWs have been trained per village. Average of 50 households per community health support groups, and 10 women action groups. Each covers around 5 families. However, there were cases we had more than 5 families respond. The upcoming slides, there would be some discussion on the results of this project, impact of this project, linked with the MSH, because MSH Management Sciences for Health, and they were doing the LQA service in their coverage area, and Bamiyan province was one of the provinces under coverage of the MSH through USAID health project. We were able, just based on the data, we were able to have the general information because we had the baseline and also some inline assessments. However, there was a kind of disconnection with the CHWs, but still we can see the improvement and continuation of the activities within those communities. The baseline and follow-up visits, antenatal care in Bamiyan sites, regular CHW visits in Rustam and Siadara, which is percentage of those households visited in each Bamiyan site, showing the different impact in pilot study than before the baseline survey in Rustam. And then women spontaneously started scaling up before project included villages in Siadara. We can see the improvement. Tetanus toxoid in Rostam and Siadara, we can see the increase from the baseline to follow-up. However, Siadara, when we did the follow-up, it was in the middle of the training. It was not yet completed, but still we can see the improvement. Postnatal care in Rostam and Siadara, baseline and follow-up result. Pressure on uterus, that was also one of the practices that we can see. First, breastfeeding within first hours, and also first hour or 8 hours or after 8 hours. Exclusive breastfeeding, knowledge of contraception, source of drinking water from spring and surface water, women's empowerment. We have two main indicators just to overnight permission and also important of decision-making process within the households or family. And then comparison with REACH. Under REACH, there were systematic interventions for entire BPHS, basic package of health services, from the community element, community health worker, CHS, health post, coming to the health facility. And it was we were able just to compare the result of this project with the entire REACH project. If we compare the information with the 1 year future generation project in Bamiyan, then we can see the significant changes in comparison with the REACH interventions for entire province. And here we can see the antenatal and also skilled birth attendance for under REACH project for the province. Exclusive breastfeeding and DPT vaccination, birth spacing knowledge and use, and it can be, if we see and also compare this with the REACH interventions and also the impact of the REACH project, which was for several years, in comparison with the future generation, which was just only for 1 year, and the intervention was only one intervention at the community level. Not specific, because under this project, we did not have specific health facilities to support directly, except the community health supervisor, which was just linked with the community health workers and women action groups. One of the issues that we were discussing that time, and it took place later on, how the future generation, also CBC department of MOPH, to work on this new approach within the catchment area of BPHS, basic package of health services. This was one of the elements that we were thinking how this can facilitate or improve and ensure BPHS further strengthen the basic package of health services. And developing in the in-service training for existing female CHWs, because the current training modules of the female community health workers under Ministry of Public Health, it was some sort of class-based orientation, and more it was on the one side communication mostly. However, there were practical sessions, and this we were thinking that how this can help the Ministry of Public Health to come up with a proper in-service training for the female CHWs. Explore how these same principles can be applied also for the male CHWs for their trainings. And this was an additional slide of asking the CHWs asked to help in delivery, baseline and follow-up, we can see. Finally, the summary of the finding. The main thing, or the main focus of the project was, in addition to adapt this and also come up with the good solutions and also approaches for the Ministry of Public Health to also think of sustainability, how we can sustain the services, the communities with their knowledge, the community health workers, the women, these women action groups. These three elements, the community statistician, community health workers, women action groups, ensure the sustainability, because we found after a disconnection for almost more than around 2 years, still those basics, they were there. The link was there. Some of those meetings, without any outside support, still it was there. And also the engagement of the community, their empowerment, the way they were working together, all this ensured the sustainability of this approach. Shortening of CHW's training, because normally the CHW training under Ministry of Public Health, Community-Based Health the department, it was around more than 2 months in different schedules of few days and then off. But coming to Future Generation, it was 25 days in general, 5 workshops of 5 days. And the women at the nationwide, that was another discussion under the project. And interestingly, this based on the, however, it was after years, but in 2007, the discussion initiated under Ministry of Public Health. In 2008, the Ministry of Public Health was able to adapt and later on just adapt this methodology. And later on, now we can see it already in the policy of Ministry of Public Health and also the strategic community-based healthcare development, CBC strategy is already within that. The name is changed to Family Health Action Groups. Mostly, this approach is just a bit adapted for the country, and now Ministry of Public Health is going for a nationwide implementation of this methodology and approach for the country. A specific focus is on the effectiveness of having or establishing family health action groups, which is equal to women action groups within the communities to support their communities and also villages to improve their health status. This was the overview or summary of the project, which was implemented under Future Generations in 2005 and 2006. But we can see the result of these efforts and also the follow-up by the Ministry of Public Health. However, it took several years for this approach to be adapted, but luckily, and that is already under the policy and strategy of Ministry of Public Health, and the country donors, they are supporting the project. And more interestingly, after more than 12 years, by now, being the Deputy Chief of Party of the project, USAID project, luckily we have under the project like 5,000 family health action groups to be established by at least from now till end of our project, which is just coming 3 years. It is also the big, I would call it, impact and result of the project, which is going to be soon, in a couple of years, country-wide, we will have the full coverage of family health action groups, which is almost the same adapted version of the women action groups of future generations approach applied in Afghanistan in 2005 and 6. Thank you so much.
Okay, well, thank you. Thank you, Dr. Paya, and we'll have a space for questions later.